These are slides that Dr. Bott and I put together. And it's on management of acute and chronic pain with co-occurring opioid use disorder. And we have no disclosures. The objectives are to describe and understand the comorbidity of opioid use disorder and pain, understand how medication for opioid use disorder, MOUD, does not preclude the need for effective pain management, and to describe some strategies to manage pain in patients who are on MOUD. So briefly talking about the prevalence of co-occurring OUD and pain. There's been several studies over time looking at this, but it's a large prevalence ranging from 37% to 64%. And it's bidirectional, this relationship, but pain often comes first. So in one study looking at over 5,000 patients, adults with OUD, 35% reported no pain, about 10% reported having OUD first and then development of pain. About 15% had OUD and pain at presentation, but the largest amount, about 40%, had pain first and then described developing OUD. So we also know that patients who had the chronic pain before onset of OUD also had high rates of co-occurring mental health conditions, other health conditions, and also we see a higher likelihood of other substance use disorder and also infectious diseases that can be correlated, HIV, hepatitis C. Just to touch upon access to care, we know in substance use treatment, historically and unfortunately continuing now, there are significant disparities in treatment for OUD and for chronic pain between African-American patients and non-Hispanic white adults. Looking at Medicare claims data from 5 to 10 years ago, these showed decreased access to buprenorphine in African-American patients who simultaneously at that time were experiencing much greater overdose deaths. So a 7.5 factor increase over the decade 2010 to 2020 than any other racial group in the US. And we also know that studies looking at approaches in this specific one was looking at approaches in primary care, sort of safety net settings. This one was in, I believe, out of UCSF, looked and saw that patients who are African-American felt increased stigmatization related to seeking treatment for chronic non-cancer pain when they had co-occurring substance use disorder history. So all of this is to say that everything that we're going through now, we really need to try to shift that as we move forward in medicine. So acute pain management, we'll talk about first. This is, I think if you've been on ECHO for a while, you've seen this slide before that Dr. Bott found online, kind of describing a patient who was experiencing that acute pain. And a vignette for what can occur. So a 45-year-old female who had a shoulder surgery with a history of OUD. She'd been treated with methadone in the past and stopped treatment each time experiencing relapse. She had been smoking 0.5 gram of heroin twice a day to 3 times a day prior to surgery. And then in the peri-op period, she was on continuous morphine and having breakthrough PRN morphine last 2 hours ago and was requesting pain medication. Again, reporting a 9 out of 10 pain. Her vitals were stable. And the nurse on the unit came to you and said, she's drug seeking. She's already getting more pain meds than any other patient. She doesn't need more. And besides, she's an addict and we don't want to worsen her addiction. So preaching to the choir here, but definitely, sometimes that stigmatization can persist both in medical care and beyond. Some commonly held beliefs, acute pain is frequently undertreated, up to 60% in patient settings, and even more so in patients with substance use disorders. Healthcare professionals traditionally have seen it more as a social problem requiring quote unquote law enforcement rather than a health problem requiring prevention and treatment. And we do see that perceived controllability that a healthcare provider may experience can equate to blaming that patient and may see the patient as manipulative. So a suggested approach is to accept the self-reported pain, knowing that pain behaviors vary. Vital signs are not a very reliable indicator of pain intensity, considering what else might be going on. So it may be that they have the active substance use disorder. They may also have pseudo addiction. They may have physiologic dependence and not a use disorder. So if bottom line is, if required, we don't want to withhold opioid analgesics from people in this acute pain setting, and then we'll talk about chronic pain as well. There's no data showing that acute pain management with opioid medication will worsen their use disorder, but we do see that untreated pain can lead to cravings, which can certainly increase their risk of a relapse. And a couple of older studies, but studies on patients who are on methadone showed that opioid analgesia for acute pain did not increase their chances of a relapse. So we know that patients who are on chronic MOUD may need higher doses of opioids to treat acute pain. Their risk of respiratory suppression may be lower if they're tolerant to opioids, and then of course they still need close monitoring. And just remembering that their opioid agonist treatment that they're on at baseline won't treat their OUD. I'm sorry, will treat their OUD, but not their acute pain. And this is a pretty common misconception that I still see in discharge summaries or kind of reports that I get from patients from the hospital. And so I think, or the emergency room, and certainly I think you probably all do as well, hear about patients' fears, not infrequently, that this still comes up, that they're going to be judged when they're seen. And so unfortunately, this does require still quite a bit of a culture change, which I think is happening through medical education, but continues to take some time to translate into the patient experience. Here are some, I'm sure that Dr. Warwick would have a much better description of this than I, but I'm just going to show these next couple of slides, giving an example of acute pain management in the emergency room. It's kind of small, but you can see in the column on the left that this is a guide that if someone's coming in on MOUD, in this case, they're on buprenorphine, you can consider, you want to continue their maintenance, buprenorphine, but you can consider, if it's not already divided, that dividing it could help with their pain. And then consider what's available to you in that situation for non-opioid analgesia. So remembering your non-medication techniques, your NSAIDs if not contraindicated, your altos, so alternatives to opioids, including some possible trigger point injections, perhaps topical if necessary, the lidocaine, your gabapentinoids, possibly nerve blocks. And then down here, we see the other options of then you may be needing to add fentanyl or hydromorphone, which in a patient who's on buprenorphine, they can still get some, and oftentimes patients are afraid that they may not be able to get benefit, but they should still get benefit when dosed appropriately from those. And then you can also consider increasing their sublingual bup if that's still, if there's room to increase that, or in the acute setting, starting IV. And then once you're through this acute setting, titrating back down to their maintenance dose. So again, remembering that the patients who are on MOUD, whether methadone or buprenorphine, have a high opioid tolerance. Naltrexone is, if they are on that form of MOUD, extended release, or if they're on it for PO or extended release for alcohol use, just remembering that if they come in on that, and we do ask patients to carry a card for these acute settings, right? In case they need to communicate that and can't, that naltrexone has a high mu receptor binding affinity. So makes it difficult for most opioids to treat that pain. And as with buprenorphine, not impossible to treat, just important for the provider to know. And then just remembering that methadone has a long half-life and is a full mu agonist, so it requires its own care with dosing with other medications. So we'll talk briefly about methadone and acute pain management. Again, as with buprenorphine, we're continuing the baseline methadone, if possible, verifying their dose from their clinic. If that can't be verified, it's safer to break it up into split dosing, TID, QID, and then adding on, if needed, the shorter acting opioids, if the alto and other methods are not helping. And then if we don't, again, know their maintenance dose and it doesn't seem like we've got the correct one and they're there for a longer period, we'll gradually increase their methadone dose. We're not going to administer buprenorphine again because that'll precipitate withdrawal in a patient on methadone. A reminder that methadone for analgesia oftentimes is more effective at multiple times a day dosing, can be prescribed by anyone with a Schedule II license. But for OUD, it's typically once a day dosing, although sometimes we will split that if they have ongoing pain, and it could help for both things. But if primary diagnosis is OUD, this is dispensed in liquid form through an opioid treatment program. And then buprenorphine and acute pain management, again, we want to employ all our non-opioid modalities. And then you can adjust, again, that buprenorphine dosing if possible to split it. You could also increase it if there's room to go up, and consider IV buprenorphine. And again, then you may need to augment with your short-acting opioids. Again, fentanyl and Dilaudid would be the ones that have the ability to overcome some of that new receptor affinity that buprenorphine has. And you can consider consulting with addiction medicine if needed. I would just quickly go through these slides, but I did want to point out that I think this is very pertinent still, this idea of in perioperative management that what we were talking about before, that patients do fear the stigma associated with it. And it's really important to try to have those conversations with them to acknowledge it. And if possible, get consent to discuss with the surgical team to try to get things set up in their favor that will provide for a best outcome. We don't, I think that I am seeing this shift more, that we don't recommend discontinuing buprenorphine before surgery, whether small or large. It is a powerful analgesic and can be combined with other opioids. So where we used to oftentimes have people stop it a couple days before, this should be still, if possible, managed with the surgical team and anesthesia. But it is most beneficial and can help with pain, but also in terms of preventing the risk of a relapse if they then have to get back on it later. This is just a nice article from Lemke et al. Out of Stanford about a suggestion for how to approach the perioperative pain management. This is too wordy and not enough time to go through, but it's a nice description, and it's in that article. And oftentimes we'll share this information with our surgical colleagues or our other learners just to kind of explain a possible approach that's been shown to be quite helpful. Essentially, in this approach, her team recommended if patients are on higher than 12 milligrams, which a lot of people are, I would say the majority are, of buprenorphine, then to decreasing to 12 milligrams in the couple of days before surgery to allow more availability of those receptors to treat on top, and then increasing to their prior dose or perhaps higher in the post-op period. This also, I will note, I think oftentimes now surgical teams are okay continuing their current dose, even if it is higher. But this is kind of a nice explanation supporting at least continuing it. And then just again, what I was talking about with naltrexone, basically want to make sure that, people are carrying a card if they're in an emergent situation, and that they can have pain management, possibly with non-opioid analgesics and techniques. But if they do need to have opioid pain medication, that it needs to be provided by someone who's trained in the use of anesthetic drugs, and can manage and monitor for possible respiratory effects if we're overcoming that naltrexone antagonism. This is just a summary slide, again, looking at the methadone, continuing it, dividing it, trying to provide a discharge letter with the last dose can be helpful for patients as well. We don't want to do the stop dose approach for buprenorphine. So the second option, again, is the recommended one where we want to continue it, use additional buprenorphine if possible, maximize non-opioids, and divide the buprenorphine dose. These are some other medications that may be used intraoperatively so that patients know that there are options. A lot of people fear either starting or being on buprenorphine because they're afraid they won't have their pain adequately treated. So it's just important that we have at our fingertips information to share with them to help assuage those fears. Okay, so checking on the time here, we've got about 5 minutes. We'll go through chronic pain management in 5 minutes. We can do this. So another picture depicting this. Some considerations to remember that a history of OUD is the single biggest predictor of misusing prescribed opioids. So it's something that we need to be cautious about. A multidisciplinary team approach, considering pain management specialty consultation is important, using non-opioid and adjunctive medications first. Again, NSAIDs if not contraindicated, possibly SNRIs, TCA or membrane stabilizing agents, or a combination. And then remembering our non-pharmacological therapies that can be helpful for chronic pain, CBT, acceptance and commitment therapy, and then a list of other techniques such as yoga, meditation, mindfulness, acupuncture, and then other interventional techniques such as, trigger point injections, TENS unit, etc. Just also recall that patients with chronic non-cancer pain with and without opioid use disorder have an increased risk of suicide. So 18%.
Good. We're supposed to get a call back to see how to do the tele.
And that having opioid use disorder does increase the odds of exceeding the cutoff for this risk by more than 3 times. So it's very significant that, and as shown by having OUD as a stronger risk factor for suicide in a setting of chronic pain than the diagnosis of a major depressive disorder. Just touching upon our responsible opioid prescribing, I think that we all are aware of these, using our screening tools, monitoring for concerning use, UDMs, PDMP, all of that can be helpful, and certainly co-prescribing naloxone. This comes up quite often in terms of how have we, over the past decade as providers, approach treatment of chronic pain with opioid use disorder. There was an update, as you all know, in 2022 to the CDC's opioid prescription guidelines, updating the 2016 guidelines that basically in 4 areas addressed whether or not to initiate opioids for pain. If you are, then selecting the opioid and dose, determining duration follow-up, and assessing the risks associated and addressing potential harm. How did we get to the need for this update? Again, going back through time, we know that the opioid prescribing increased 4-fold in the US in the first decade of this century. In 2014, the FDA issued warnings, first for extended release, then for immediate release. And in 2016 was when the CDC released their opioid prescribing guidelines. However, it did cause some benefit, but it also had detrimental effects, in part stemming from actions that weren't consistent with the intent of the guidelines. So sometimes not treating with opioid pain when it really was something that the patient could benefit more from, and also the abrupt cutoffs that oftentimes led people to turn to non-prescription sources. So all of this has been important for the medical community, kind of reassessing our care. Monitoring is still extremely important, not having them as first-line medication for chronic pain, but being sure that we're not kind of overstepping. And certainly when people were in part with those 2016 guidelines getting cut off abruptly. I think just in the interest of time, I'm not going to go through this other vignette. But in general, we're talking about a patient with chronic pain who once, when she was on full agonist opioids and then switched to buprenorphine, she found actually better control of her pain. In this case, it was a split dose that helped. When chronic opioids are required for pain control, it might be more difficult when they're on buprenorphine already. If the approach of adding non-opioid medications and continuing with buprenorphine, increasing and splitting the dose, if not done already, if that doesn't help, it may need to be discontinued. But buprenorphine, importantly, can sometimes mitigate opioid-induced hyperalgesia. There's many good indications for it for chronic pain. I won't read through this list right now. But you can see here, this study looked at conversion of high-dose opioids to buprenorphine for chronic pain, and you can see the morphine equivalents here, the blue representing pain before, the red pain after, and you can see that the pain score significantly decreased, and that's likely with this very high-dose MMEs. They were experiencing hyperalgesia that the buprenorphine shifted. This is reviewing that for chronic pain, the sublingual forms may not be, that they're not approved for treatment of chronic pain, they're often used though, but a buprenorphine patch for a primary diagnosis of chronic pain can be effective. And then you can augment with other opioid and non-opioid analgesics. And I'm also going to skip this vignette because it is 12:30. In some cases, the patients, that should say opioid use disorder, might be better treated with methadone. So just remembering that we may need to transition to that. And if a patient has chronic pain that has been deemed necessary to require opioid analgesia, they're really not good candidates for naltrexone, again, because of that antagonistic effect. So you'd want to consider buprenorphine or methadone. So in conclusion, we want to consider an integrated approach to both acute and chronic pain with co-occurring OUD. Consider the safety and effectiveness of pain treatment in a given patient so that it's just going to be different for each individual. Again, these racial disparities in the treatment of pain and co-occurring OUD are significant and must be addressed. And consider the effect that stigma associated with living with OUD plays in the patient's experience. So I'm going to leave it there. And if you have any comments or questions, we could probably take like a minute and then we'll switch over to the case. Thank you.